Hey, good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites. We're back here in this Dolph Simons family studio. And Dolph, if you're ever out there, thank you. Hey, we're about 3.5 years into the COVID pandemic, and doctors have a very good picture. I don't know about that. We have a better picture of what COVID is. We're still kind of building the airplane while we fly it, but the airplane, it's flying. So we kind of know how to prevent it. We do know how to diagnose it. And there are drugs and things we could do to treat it, and vaccination does work. But the same cannot be said about long COVID. As it stands today, we don't have a great way to diagnose this kind of syndrome, this long COVID. In fact, there's no really widely accepted definition. And in the meantime, there are a lot of patients, millions of patients, are living with symptoms. They kind of want some answers. We're going to devote the next 2 Open Mics programs to long COVID. Next week on Show Me the Science, we'll hear from researchers who are trying to help define what long COVID means. But today, we're hearing from our expert panel of doctors here in the Dolph Simons Jr. Family Broadcast Studio. Dr. Dana Hawkinson, of course, he needs no introduction. Awkward. Dr. Bryan Beaver is an internal medicine specialist. He's been on this program before. He's seen a lot of long COVID patients over the last 3 years, and he really has been sort of in charge of the long COVID program at KU. Dr. Molly Jackson is a gastroenterologist. She's also been here before. She's going to help us drill down a little deeper into long COVID's link to the gut. And in fact, it's kind of what does COVID do to the gut? To the gut. First, though, let's do some morning rounds. Wow. It's hot here in Kansas City and across the country. Fortunately, we're not Phoenix, but our emergency department has seen an uptick in heat exhaustion and heat stroke patients. Dr. Bryan Beaver told us the key difference between heat exhaustion and heat stroke, it's your mental state. What someone is confused or delirious, that's heat stroke. You're in trouble. You need to cool down before you get to that point.
If someone's feeling heat exhaustion, but they haven't crossed over into that altered mental status of heat stroke yet, first thing is need to get out of the hot environment if at all possible. Need to start drinking fluids and taking those in to get cooled down. If someone is to the point that they are vomiting, they really need to come to the emergency department because we're worried that they're not going to be able to stay hydrated at that point.
Hey, let's say that again. Because if you spend too much time outside, drink as much fluid as possible. It's all about hydration, hydration, hydration. Come back to that point. If you're vomiting, you can't stay hydrated. If you can't stay hydrated, you're in trouble. If you start having mental status changes, you're in trouble. What that means is there's end organ damage from the amount of heat you have experienced and your inability to get rid of that heat. That raises your body temperature. It does significant damage to your bodily organs. It can lead to death. As an ICU physician, I've seen a lot of that too much in the summer. Don't be that person. Stay hydrated. If you need help, get help. Okay, turning back to our topic of long COVID. Dr. Comfort, we say there's not a way to diagnose long COVID. So help the audience understand how you see and treat a long COVID patient, even if you're not quite exactly sure what the definition is. So just kind of work with this. What's the difference between I've got COVID and I have symptoms like I was tired for like a month and a half or 2 months after COVID, but that didn't give me necessarily long COVID.
No, it's true. So there's not, like you said, there's not a clear definition or clear diagnostic criteria, but we do know quite a bit about this, or we're learning, maybe I'll say that. We're learning quite a bit about this. There's a subset of symptoms that are widely reported after having COVID: fatigue, shortness of breath, chest pain, a lot of GI symptoms, which Dr. Jackson will talk about. But so I think really how we determine if someone has this, if they develop those symptoms after they have a COVID infection, and it's been going on for a while, so at least 4 weeks. So we want them out of the acute phase of illness. Some people would say it needs to be 3 months or longer. If they're having all those symptoms that are lingering after that, we feel pretty comfortable diagnosing them or calling it post-COVID conditions, long COVID, something like that. One other thing, we need to make sure that we can't explain the symptoms from something else, right? So lots of things cause fatigue, for example. So we spend a lot of time ruling out other things, checking their thyroid, checking their electrolytes, fluid status, etc. If all of those things are checking out okay, we feel pretty comfortable calling it post-COVID conditions or long COVID.
So a severe COVID illness can affect pretty much every organ in our body. Talk to us a little bit about that, because it's lungs, heart, brain, kidney, every part of it, right? Does that have an impact on whether or not you're going to develop long COVID?
It does, yeah. So, I mean, just like what we've seen with acute COVID affecting every system in the body, we've seen that with long COVID too. We've seen literally every system covered, I think, at this point. We know that people who have more severe acute illness, so those patients needing hospitalization, for example, during that acute phase, have a much higher chance of developing lingering long COVID type of symptoms.
So if you've been in the ICU, for example, and you've had a lot of lung impact to your lungs and developed some lung injury, we predictably can say, yeah, you're going to have long COVID because the recovery time for that can be 6 to 12 months. We know that's pretty standard from people who have been critically ill. But is it possible that you feel better from long COVID and then 2 or 3 months later suddenly you feel worse again?
Yeah, and that's one of the perplexing things about this is many of our patients that we've seen will describe kind of this cyclical pattern, you know, and they start to get better and then they start to get worse again, and that really has a toll on your mental health, right? So you feel like you're finally getting out of this and seeing the light at the end of the tunnel, and then you start having a backslide. That can be really challenging from an emotional standpoint to get patients through that. But usually I try to counsel my patients that there are going to be ups and downs with this as the recovery. It's not a smooth trajectory down. It's going to be lots of bumps along the way.
And then is the long-term outlook decent? Will people eventually recover?
You know, we're starting to get a little bit more information on that as time goes on. So now we're 3 years into it. So we've had some patients that do have some symptoms that have lingered about 2 years now. But most patients do tend to get better. That 6-month mark is really a key kind of time frame where we start to see a lot of patients recover after that. But there is going to be a small percent of patients that we think that this is going to end up being a chronic, maybe a lifelong sort of endeavor for them.
Yeah, that stuff, and it's a good reason to make sure you follow the rules of infection control, because even though you may think COVID is done, COVID is not done, and the problem is this long COVID thing is pretty nasty. Hawkeye, is that the same as other viruses, or is it different?
Yeah, we know that you can have some long-lived or post-infectious symptoms as well. It's just certainly, I think, with the number of people that have been affected and infected with SARS-CoV-2 and COVID-19, we are just seeing that in a greater proportions than we have before.
Is it inflammation? Is it damage to an organ? What's the cause of this? What's going on in our bodies?
I mean, I think the answer is yes. There are several proposed mechanisms, and one is continued ongoing inflammatory state. So your immune system, for one reason or another, is continuing to release chemicals and cytokines and just be active in your body for one reason or another. Another reason is maybe there was some disruption of some of your blood vessels, and that can cause issues such as the blood clotting. That is one mechanism proposed for things like brain fog, where maybe you're just not getting enough blood flow. There are continued nerve disruptions as well that can be caused by the secondary effects of the infection. And then also disruption of your normal microbiome, your normal flora, whether that's in your gut, in your respiratory tract, just still causing these disruptions. So there are several proposed mechanisms. We don't exactly know what exactly it is. There was also a proposed mechanism of maybe you still have some sort of viral proteins or maybe low-level replication that's going on that's causing some continued inflammation. So we don't know. We know that we are investigating those types of things and questions and really looking for it. But also maybe some autoimmunity. So maybe your immune system is reacting against other proteins or areas on your body, and we know that there are autoimmune diseases out there, and so it could be some mechanism like that. So to answer your question, it's yes, there are several proposed mechanisms as to why these continue to happen, why people are continuing to have these types of symptoms, but we don't have any definite answers just yet.
So there's like mononucleosis from Epstein-Barr virus or CMV, et cetera. Is it like that, or is it different?
It's not exactly like that. Those are typically more during the active infection. These are mechanisms that are occurring after this active acute infection, and that are prolonged, just as Dr. Comfort said. Is it being 12 weeks after your infection? So it is a little bit different, but again, we don't have all the answers just yet.
And last time I pestered you, at least for this point in time, of course I'll pester you again here in just a moment, but in your view, does vaccination help this, hurt it? I mean, does it help prevent some of this? Give us a sense about that.
Yeah, and I'll certainly ask our guests too to weigh in. But for sure, again, we had a question as why wasn't the vaccine marketed and authorized for reduction in risk of long COVID. You know, this was a post-marketing effect that we saw. The best evidence that we have is those people that were vaccinated. And again, now we are in a much different state, both as an individual with individual immunity and us as a population, than we were back when the vaccines were first introduced. But what they did see, and what our best evidence supports, is that there was probably a 15 to 30% reduction in your risk of getting long COVID if you were vaccinated, as opposed to those people that were unvaccinated.
Okay, Dr. Comfort, I'm back to you. So give us a little comfort here. No pun intended. Yeah, actually there was. But do you think the majority of patients do pretty well with long COVID eventually?
The majority, yes. We tend to focus on the minority of people who continue to struggle, but yeah, the majority of patients who have long COVID symptoms will improve over time.
And are there therapies for this?
Not direct therapies. So there's lots of different research out there. Maybe next week you guys can talk a little bit about that. But you know, they're using things. Most of them are off-label things. Metformin, I've seen studies on, which is a diabetes drug.
Really?
We've seen.
Again? We're bringing metformin.
I know.
Back. Did you bring it? Did you actually?
That's in the New England Journal actually.
Okay.
So big study. You know, Paxlovid.
Did it
Usually
help?
these are.
Did it help?
Now, here's the caveat. It helps with certain populations, patients who are overweight and obese, and patients when they're acutely ill taking it.
Okay.
So potentially.
Yeah, and I think another caveat to that, I think it was a very well done study, but I think another caveat to that is it was in a different time as well.
Yeah.
Most of it was done pre-vaccination as well, the ability of us having vaccines. So I think that is one important thing we need to continue to evaluate moving forward when we talk about certain things such as this. Is what time during the pandemic was it? Was it very early on? Was it after vaccines had been introduced, or before vaccines, or was it before people had been infected and reinfected, things of that nature?
So history actually does matter.
So what does?
The history actually matters.
Yeah, sure
There you
does.
go.
Yeah.
All right, Dr. Jackson. Now, COVID in the gut.
Yes.
Talk to us a little bit about that, because there are a lot of people out there with some significant GI diseases, and we know that during the acute phase of COVID, you can present with diarrhea or nausea and vomiting and other sort of GI symptoms. But on the other hand, you also have all those folks out there with inflammatory bowel disease and Crohn's disease, et cetera. How do they do?
Yeah, so when you look at kind of just the general GI population, I think up front, you know, we talk about how SARS-CoV-2 really enters the host, and that's through a specific receptor called the ACE2. And I'm mentioning this because I think it gets us kind of on the broader picture. But the ACE2 is highly expressed within the GI tract. It's in many organs, but highly expressed there. So once the virus attaches, it elicits this cascade of response, and inflammation and destruction. ACE2 also has kind of a secondary mode here, where it independently will help bind and regulate amino acids and peptides. And that's really important because it helps the lining and maintain stability of the GI tract, and also the microbiome. So when the virus attacks, this can really disrupt both. Now, coming back to kind of general GI and then IBD and other entities, celiac disease, where we think that might have some other constitution of having increased, thankfully, we haven't seen worsening in those patient populations. They have not necessarily gotten worse disease. And many of them are on immunosuppressive therapies. The one caveat is those who've been on steroids. We have seen a higher propensity of worsened disease on patients who have other underlying illnesses who are currently being treated with steroids.
Yeah, so that steroid thing is kind of a warning to us all, right? Because the steroids aren't just necessarily the ones for GI disease. They could be for other diseases, could lead to some bigger problems.
Absolutely.
With COVID-19. Okay, so some people call the gut the second brain. I don't know that my wife would think about me and my gut like that, but maybe so. But it does have a lot of neurons. It's got kind of its own neural system, and we could spend a whole show probably talking about just that. Might a viral infection change things in the gut's own nervous system? And actually, you probably need to talk to us a little bit about what we mean when we say the gut's own nervous system.
So the GI tract definitely is a second brain or second emotional center, if you will. And I think every person has probably experienced that in one way or another. When you have a big event or presentation coming up, you can get nervousness, some GI upset. People describe, you know, some excitement with butterflies or something that's gut-wrenching. The GI system has its own nervous system. It's called the enteric nervous system, and it is constantly sending messages back and forth to the brain and receiving signals from the brain. We now know that is the gut-brain axis, and how important that really is not only for GI health, but also for the health outside, other systemic diseases, neurologic, rheumatologic. We've also learned that the microbiome plays a huge role in maintaining that signaling pathway. So any virus that were to attack that can affect not only the kind of structure in nerves, but also that microbiome. So the signals get stunted, they get changed. That's not the appropriate communication anymore. And that can present in a lot of different ways. It can slow GI motility or make it more rapid. Hormone release is different. The way we perceive pain, those pain receptors can certainly be affected where you have heightened sensations of pain. There are some well-known GI syndromes, irritable bowel syndrome, functional dyspepsia, that we know are triggered by certain infections, bacterial or viral. So you develop these post-infectious irritable bowel syndromes. We're talking about long COVID now. We don't know everything about it, but it's very possible that it may fall into one of these post-infectious brain-gut axis disorders.
You know, that whole gut has its own nervous system is a kind of a cool thing to sit and think about. I've always thought my gut might be a little bit of an alien, and I think you've just proven it to me. I think you've just described it. And it can think, and it can react, and it can feel. And so much of our body is so interrelated. It's just a fascinating topic. And thinking about how whether COVID could impact that is, I think it's a bit of a mind bender. In this case, that's maybe a gut bender. I don't know. Dr. Comfort, you've seen an interesting theory about long COVID in the brainstem. All right, let's talk about that. What's the theory?
Well, yeah, so it's a hypothesis. So they're, just like Dr. Hawkinson was talking about, people are looking at everything and every possible mechanism here. But this may tie into to what we were talking about earlier, inflammation, maybe the small blood vessels getting affected. But if that's occurring in the brainstem itself, that can have wide spread kind of symptoms that can present with that. Our brainstem is very important, regulating lots of autonomic processes, our blood pressure, heart rate, sends out signals to the gut for GI motility and those sorts of things. And so there is some thought here that potentially that is tying into a lot of these symptoms that people are experiencing. So just another thing for folks to look into, and certainly we're working with our neurology colleagues on that as well.
Okay, so we got a neural system around the brainstem, we got our upper brain function, we got the neural system in the gut. All of it can get involved with COVID and long COVID. Man, I'll tell you, it can be a complex world out there sometimes in medicine. Hey, we're going to try and answer your questions. Send them using the links on your screen, YouTube, Facebook, Twitter, or email, the Medical News Network. Let's first of all check our COVID count. Doc Hawk, the numbers are still staying pretty low.
They are pretty low, a little bit higher than we had been. We had been down, I think, to 2. But our active infections have
gone up. That was when you were on vacation. I just want to point out, I got it to 2, not you.
You're pushing them up.
I am. I'm trying it.
So 8 total, but 5 active. Unfortunately, 1 in the ICU and 0 on the ventilator.
You know, if you told us at the beginning of the pandemic we had 13 patients, we said, oh my God. But now it's like, oh, that's a pretty good number for us. We're not 250.
Yes.
We'll see what the fall brings. But hopefully some vaccination coming out about then. What do you think about that? We're going to get that monovalent out soon?
Yeah, I think we're believing it should be sometime in the next 6 weeks, so maybe that early September period. I haven't seen any new updates on the availability, but just as you said, Steve, it is going to be a monovalent, so it's just going to be that one spike. It'll probably be an XBB spike, which is a sublineage of that Omicron variant.
And it's been hanging around for a while. It remains sort of the dominant strand. I looked that up yesterday trying to prepare for this program. But it's still out there. There's still a lot of XBB variants out there, but they still make up the dominant numbers.
Yep.
Okay, so the CDC has announced a new program, the Bridge Access Program, to help uninsured and underinsured patients. You know, COVID vaccines will be transitioning to the commercial market. We got to make sure that everybody can still get them. It's going to make the COVID vaccine free at certain health departments and pharmacy chains. But I think the program is temporary, ending in December of 2024, Hawk. Mm-hmm. What do you think?
Yeah, so I think this is a good step for underinsured and uninsured people. I think we need to continue to have this infrastructure, not just for COVID vaccines and treatments, but for healthcare in general, preventive healthcare in general. So I think it's a good step forward. I know that there was a lot of concern about a lot of these programs ending once the pandemic or the health emergency was ended, on paper, meaning reduction in some of these resources. So I think this is a good step to keeping, again, our most vulnerable patient populations with reduced risk of severe disease and having to come to the hospital. And again, it's for vaccines and for treatments as well.
So the CDC is trying to get a longer-term solution and act it into law. Once we know where you can get free vaccines, you can bet we're going to talk with you about that and encourage you to get those, especially that new monovalent vaccine. Yeah. Hey, one of our regular viewers asked about COVID deaths. Gene Rardon asked if COVID deaths were overreported. Okay, this is a little bit of a complicated topic, and Hawkeye, you and I can kind of tackle this together. This ties back, are you dying from or dying with COVID? Now, first of all, back off for just a minute, not back up. The truth is, whether we're talking about influenza or any other infectious disease, we're going to have the same challenge, right? Are you dying from that influenza episode? And we saw a lot of influenza deaths every year. Are you dying with influenza? And then we'd ask ourselves, if you had a heart attack and you had COVID, well, did you die from the heart attack or did you die from COVID? Here's what we know. Viruses cause lots of problems inside our body. We know if you have chronic health conditions, it always makes you more vulnerable to other diseases. So whether you have influenza, CMV, SARS-CoV-2, or some other viral challenge or some other viral illness, metapneumovirus, then those viruses cause inflammation and challenges to your body. It does actually make you more likely to clot. We know that COVID, one of the challenges, it makes patients more likely to clot off things. They can have big blood clots in their lungs, they can have small blood clots in their hearts. So did you die from COVID or did you die of a heart attack? It may be that the immediate cause of death was a heart attack, but that heart attack was caused by clotting and inflammation because you had COVID. Had you not had COVID, you may not have been in the hospital. Now, it can also be true that had you have underlying heart disease, so you're already at a higher risk for death from a heart attack. But that immediate heart attack may well have been precipitated by COVID. So it's a very hard ball of twine, I think, to unravel, Hawk.
Yeah, no, I certainly agree. And I think this also goes to, this is a very good question. And just, again, things in medicine and science aren't always black and white. Just so we heard Dr. Comfort talking about the brainstem and what are the mechanisms there. But I think we also have to continue to understand what time, what period in the pandemic are we talking about. So very early on, we believe that the deaths were massively underreported. Why? Because there wasn't testing done. So if you don't test for it, you can't diagnose it, and so you don't know. There were a lot of people who weren't dying in healthcare facilities, but were dying in the streets or at home. So those aren't really getting counted. So that was very early on in the pandemic. And again, we aren't just talking about our country, we're talking about different places around the world. But then certainly once vaccines became available, people were getting their primary series, were getting their booster. Once treatments became available, then it made it a little bit harder. And again, are you in the hospital with COVID, just maybe found incidentally or because of COVID, or, and as Dr. Stites, you have talked about so many times and again now, did your chronic conditions that you have and live with on a normally daily basis, were they kind of pushed over the edge where you became acutely ill because of complications that COVID may have caused? So I think it is very, very hard to tease out, but we know that that is true, that SARS-CoV-2 or COVID-19 infection can exacerbate some of your chronic acute illnesses, especially when you're dealing with the major organs like the heart or the lung. And then of course those complications with blood clots, just to name a few as well.
You think about somebody who's very, very chronically compensated, but they have to work at that. For example, a heart failure patient. It sounds funny. A heart failure patient can eat a bag of potato chips and go into pulmonary edema and have shortness of breath. One bag of potato chips because of the amount of salt that's in there. And you think, well, see, they have heart failure because of the potato chips. Maybe, that could well be true. But COVID could also tip patients over. And the same thing can be true for advanced asthma or lung disease. There are little things that can tip you over, but COVID can be a really big thing. It can really push people over. And to your great point, and that was a great point, there will probably underreport a lot of COVID deaths because we don't know if they're positive or not, especially early on, and I would even argue longer on. So it's a sticky wicket. But that same sticky wicket applies to influenza and all these other infectious diseases. We have the same challenge. COVID is no different. It's not like we try to go out and over-report COVID deaths to make everybody excited. No, this is the same way we report influenza deaths. It's the same way we report hepatitis deaths or deaths from AIDS. Because sometimes it's hard to tease apart what's exactly the cause and what exactly is the result.
And I think on one side of that coin too is, does it really matter at this point? I mean, certainly for people who are just looking at numbers and maybe, do they believe COVID was real? Was it a real pandemic? When you are sick and ill, when you come to our facility, we are going to be aggressive and treat you as optimally as possible, no matter what that cause is. So I think that's the other thing to remember is these are real people who are coming in and needing medical care.
And we got to treat their COVID.
Yeah.
All right, we're going to go back to the studio and ask, because the studio will be with Jill Chadwick, who's sitting in today for Alexis Del Cid. Jill, welcome back to our program. Thanks for being there today. I bet we have some questions out there.
We do. I want the first one, though. My husband and I'm so sad to say, finally came down with COVID 7 weeks or so ago. We'd been traveling. We had two opposite experiences. His was all headache and fever and respiratory. Mine was all in my tummy. Pain. It wasn't until I got chills that I even tested, and I was shocked because I have GERD all the time, acid reflux. So did they go to the different places just because my husband is susceptible to migraines and I'm susceptible to GERD?
Oh, that is a great question. Okay. I think that's a team answer here. What would you say?
I would say, yeah. So just like Dr. Hawkins was saying, so if you have some underlying medical conditions or underlying inflammation in the gut, for example, in this case, you're going to be more susceptible, might kind of tip you over the edge in that. And so everybody experiences COVID differently, it seems. That's certainly been my experience with my patients.
Molly Jackson.
Yeah, I really would concur. I think everyone experiences a little bit differently, and certain underlying illnesses could predispose you to a certain organ system being affected a bit more than others. We've certainly seen that.
So when I had COVID, I have a little bit of reflux, although it's a lot better thanks to you guys because I followed my low FODMAP gluten-free diet. But the thing I was impressed by was I had a little bit more chest tightness. I have just a touch of underlying asthma, and that was my predominant symptom. So going along with the point, where you have inflammation is where you have inflammation. Hawk.
But I think we also know, just as you brought up during this show, Dr. Stites, other viral respiratory illnesses can, cause some symptoms like long COVID. We know other viral respiratory illnesses can also affect other organs, like giving you headache or giving you GI upset or stomach upset as well. And that could be part of just a universal mechanism, maybe, if you will, for some viral illnesses.
Yeah, so COVID is really not different from all those other things, is it? It just can be a little bit more severe. We're not seeing quite the same number of deaths right now. Why do you think that is?
Yeah. I mean, I think it's a fairly easy answer. Certainly there is, it's not just black and white, but I think it has to do with individual immunity. So those people that were vaccinated, boosted, or infected and reinfected have now built up a good individual immunity. And if you are not at high risk, meaning older age, certain comorbid conditions, especially immunosuppression, you more than likely will do well with your second or third infection, and we have seen data to support that. So I think it's individual immunity, and the best data that we do have about exposures to spike and developing that immunity is really it's that 3 exposures. So hopefully it's through vaccination rather than infection. But once you've had three exposures, you've really started to develop your best repertoire of T cells and B cells that create antibodies as well. So that's individual, but I also think there's an overall population immunity where now most of the population has been either infected or vaccinated or both. And so that will help reduce the overall impact on the population and hospitalization, but also understanding and unfortunately remembering all those highest risk patients, but even those that were low risk that have already unfortunately passed away from the disease as well.
Jill Chadwick.
Yin Lei wants to know, and thank you for all that too. It just reaffirms what you guys have been saying over and over again. Yin Lang wants to know, have there been any cases of COVID patients presenting with swollen finger joints or other joints?
I believe that we have seen some joint involvement from COVID.
Yeah, we have. I've seen it probably more in the long COVID group myself, but yeah, we certainly have. And so probably that inflammation is settling in certain people's joints, maybe a little bit of autoimmunity involved with that potentially, but yeah, we've certainly been seeing that.
Lynn wants to know, how many long COVID patients are there? Do we know?
Oh, wow. That's a hard question, right? Because it's hard to actually quantify that.
Yeah, it's a
we don't
lot.
even have a working definition, so it's really hard to say what the number is, but
Yeah,
go ahead, take a
well,
crack at it.
so it's the best estimates are probably around 10%, or that's what's been published so far. 10% of patients who have been infected with COVID can develop some form of long COVID, and so I mean that puts us in the millions across the country, right? Probably 20, 25. This is a rough estimate, of course. In the metro area, I mean, if we do those same numbers, we're probably looking at 150, 200,000 patients or so that have had or are currently experiencing long COVID symptoms.
And you got to remember that COVID's affected now like 90 to 95% or more of the population, right? Jill, you were one of the last remaining folks. Has everybody here, like I had COVID in November. Anybody else here had COVID?
Not that I know of.
Hawkeye doesn't. Have you?
I have.
Molly's had it,
I've
Dr.
had it.
Jackson,
Yeah.
Dr. Comfort. So we've all had COVID, and Hawkeye's just not admitting it. I'm going to check.
I've been in enough high-risk situations that I would expect it, but I have not had
He's
symptoms.
also megavax. He's the most vaccinated person on the planet, and I
did
think
like-
he's proof that megavax works.
I did like getting my vaccination. I don't think it hurt me at all. Has it? I don't know.
No, I
Maybe it
think
has.
you're more handsome than ever.
But no, Steve, you made a great point about long COVID. And I think we have to understand this, and the population has to, the people have to understand this. The definition of long COVID, it is very difficult and hard to define because it is so much based on subjective feelings. Symptoms of brain fog or fatigue, symptoms of the cough or shortness of breath. But what are those symptoms? And are those symptoms truly due to also your COVID infection or just other things as well? So I think that is one of the major caveats of any of these long COVID studies that are done as well.
Guys, how do all these unknowns, and I see that's one of the questions. Talk about this question about unknowns, Jill Chadwick.
Well, Reese wanted to know, how do the unknowns about long COVID make it harder for doctors?
Yeah, so Dr. Jackson.
Yeah, I think it makes it difficult because there's many things that go under the umbrella with some of the symptoms they present with. And as Dr. Comfort mentioned earlier, I think we really need to tease out, is this truly secondary to a COVID infection, or is there something else that is going on? Because there are multiple entities that this could be. It makes it very difficult to then not only not have a definition, but then place these patients in this group that we would consider a possible long COVID.
Jill Chadwick.
Jo Ellen has a great question. She wants to know, is there any age group that is more affected by long COVID, and why?
Oh, that is a
that's a
great
great question.
question.
Yeah, that is a
Dr.
great
Comfort.
question. So yeah, what we've seen so far is patients who are older tend to be more susceptible or have a higher percentage chance of developing long COVID. Very similar to what we've seen with the development of severe acute illness as well. So it kind of matches
Let's
that.
define older.
Older, 65 and older. Yeah.
That one. I'm
Maybe,
still
okay.
under it, Chadwick. How about you?
I skate
Yeah.
under the wire.
Excellent. Yeah, I think some people
Okay.
would say 55 or 60, right? But it clearly, the older you are, the more risk you are, which is true for any disease. It's just got to remember COVID can be deadly.
Yeah. Jeremy wants to know, during the worst of this, it seemed like pretty much any and every symptom could be tied back to COVID. Is that unique to COVID, or is one, and we've talked to other viruses will do the same. He just wonders, are we paying more attention now?
Okay, I think there are a lot of viruses that can present just about any way. I think about my population, and sometimes the same bug can affect one person in their gut, and one person in their lung, and one person in their hip. And we don't really always understand what that is. We certainly knew it was true with COVID, though.
Mm-hmm. Yeah, and I think the answer is yes. I think number one, it's a new disease. People are more heightened awareness, and so they may be more sensitive to changes that they would not have had prior to SARS-CoV-2. So I think that is it. But I also think in greater proportions, again, because our body has really never seen anything like this. Even the common cough and cold coronaviruses, although there may be a little bit of conserved areas that our bodies can recognize sometimes, we really have never seen this virus before in our life. So I think it's a combination of all of those things.
That's
Joe.
all the questions I have, and I just want to say that my husband and I both were really sad that we got COVID because we worked so hard and we were so proud that we didn't get it. But we went traveling, and honestly, we were not as faithful with our masking as we should be, and I think we paid for it.
Well, and you know, that's the story. And again, life is a balance, and you have to still enjoy the ride. So I want to ask our resident long COVIDologist. How about that one?
There we go.
Covered?
We're putting that on the
COVIDology,
CD.
baby.
Yeah.
You and Hawkeye, you guys they're kind of COVIDologists, but you're the long COVIDologist here in the room. So you really have spent a lot of time specializing in helping run a long COVID program, seeing a lot of patients. What's the role of a specialist versus a primary care doc in this world?
Well, it's certainly a team balance, right? And we work with the team all the time here at KU. We have a great set of specialty physicians, and we're always going to coordinate with them. But the primary person you should go to first is your primary care physician. They're going to do a lot of that kind of baseline workup, right, to rule out the other causes of your symptoms. And then if we're still kind of getting to the end of that line and not figuring that out, that's when we're going to be calling in our specialists like Dr. Jackson or a pulmonary specialist or whoever it might be. And so it's certainly going to be a team focus, but start with your primary care physician. They'll be able to get you started, and then they'll get you connected from there.
Given that 95% of patients have had COVID and about 10% of patients probably develop long COVID, most primary care doctors have gotten really good. They have to be COVIDologists, really, because they see so much of it now.
That's exactly right. And to the point that we've had already, right, we've seen similar things like this before, after influenza, after other infections. So it's not, completely new. The volume is really the big challenge right now that we're dealing with. And so, lots of people got COVID who didn't have immunity. So I think we saw a huge number of these patients over the last several years.
Yeah, big darn deal. Okay, this has been a great discussion. I want to say how grateful I am to our guests for being here. We've had a terrific panel. These are all great folks, great doctors, and you'd want to be cared by any one of them. So let's hear final thoughts from before we go, Dr. Jackson.
Yeah, I think there's a lot of people who are probably suffering ongoing symptoms, whether it is long COVID or other. If you are having ongoing symptoms, I would say seek, evaluation. While there may not be a quote-unquote cure for all of this, there's a lot of support that we can offer you to improve symptoms and overall quality of life.
All right, Dr. Comfort.
So the best way to not get long COVID is to not get COVID in the first place. And so still staying diligent out there, wearing your mask when you need to, hand washing, all those sorts of things. And then most importantly, getting vaccinated is always the best thing that we can do to kind of prevent this. So.
I will once again be bearing my biceps on this very program sometime in September, and I'm going to show off how much I've been working out. Yes. Not really. Yeah. Okay, Doc Hawk, final thoughts.
Yeah, I think we are all thankful that the number of hospitalizations, severe disease, and death has been significantly reduced since even a year ago. But we still have a long way to go. We are hoping that the circulation of SARS-CoV-2 is going to continue to be low. We know we are getting ready for respiratory viral season coming up here in a couple months, which is going to be typically September to April. So it is vitally important to continue to do those preventive measures. And for this year, we're going to strongly encourage and recommend influenza vaccine, obviously the monovalent COVID booster that will be available, and also this year, especially for those highest at risk, our elderly patients, we have the RSV vaccines available as well. All of those things, getting those vaccinations will help reduce your risk or a loved one's risk of going to the hospital and having severe disease. So we will continue to update you when those vaccines are available, and hopefully keep you safe throughout the winter.
Hawk, I think you make a great point about seasonality. Thank you. And here's what we know. COVID numbers are low right now, and they're low because people are outside. A lot of disease has been in the community, vaccination. It's getting hot. And remember, if you're going to go back inside again, just beware. If you're sick, don't go around a bunch of folks, and make sure you stay tested. Faith, hope, and science can make sure that we're safer and better. But it takes all of us acting responsibly as individuals to keep all of us safe. So thanks again to all of our guests. Thanks again to our audience. Remember, faith, hope, and science.
Coming up Friday on the Morning Medical Update. Mutant genes make some people almost destined to get cancer. One woman decided to change her destiny and had her stomach removed. I'm Jessica Lovell on the next Morning Medical Update, the genetic side of cancer and what it means to you if a parent or grandparent has cancer. Monday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.